Angiography. Angiography is the study of the blood vessels. An angiogram uses a rich opaque substance or dye to make the blood vessels visible under X-ray. Additionally, angiography is used to detect abnormalities or blockages in the blood vessels throughout the circulatory system and in some organs. The procedure is commonly used to identify atherosclerosis, to diagnose heart disease, to evaluate kidney function and detect kidney cysts or tumors, to detect an aneurysm, an abnormal bulge of an artery that can rupture, leading to hemorrhage, tumor, blood clot, or arteriovenous malformations in the brain, and to diagnose problems with the retina of the eye. It is also used to give surgeon an accurate map of the heart prior to open heart surgery or of the brain prior to neurosurgery.
Angiograms are performed or supervised by consultant radiologists in the X-ray department. Most vascular surgeons do not perform the angiogram themselves. There are three ways in which an angiogram may be performed. First, the digital subtraction angiography or DSA. Second, computed tomography angiography or CTA. And lastly, the magnetic resonance angiography or MRA. Digital subtraction angiography or DSA. DSA is now regarded as the conventional way of getting pictures of the arteries. The site of the area to be investigated is numbed with a local anesthetic. This usually stings as the anesthetic is injected. The artery to be investigated is then injected with contrast, which then outlines the arteries beyond.
Computed tomography, angiogram. As CT scanners have become more sophisticated and quicker, they can be now used to generate an angiogram. Like a DSA, contrast is injected, but instead of injecting into the artery, the injection is made into the vein in the arm. The arteries anywhere in the body can now be outlined.
Magnetic resonance angiogram or MRA. An MR scan uses a magnetic field to generate images. Like CT, it can create three-dimensional images on a computer. Contrast or gadolinium is injected into a vein in your arm. Any arteries in the body can then be viewed as a two- or three-dimensional image. The image on a computer can be rotated and viewed from any angle.
What happens during angiography? Angiography is done in a hospital X-ray or radiology department. For the test, you'll usually be awake, but may be given a medicine called a sedative to help you relax. You lie on an X-ray table and a small cut or incision is made over one of your arteries, usually near your groin or wrist. Local anesthetic is used to numb the area where the cut is made. Then, a very small flexible tube or the catheter is inserted into the artery. The catheter is carefully guided into the area that's being examined. Then a contrast agent or dye is injected into the catheter. A series of X-rays are taken as contrast agent flows through your blood vessels. So when the catheter reaches the area under study, the contrast agent will be injected through the catheter. By watching the fluoroscope screen, the radiologist will be able to see the outline of your blood vessels and identify any blockages or other irregularities. Angiography procedures can range in time from less than 30 minutes to 2 hours or more. It is important that you relax and remain as still as possible during the examination. The radiologic technologist and radiologist will stay in the room with you throughout the procedure. If you experience any difficulty, let them know. You'll usually be able to go home a few hours afterwards.
So next is angiography procedures.
Cerebral angiography is used to detect aneurysms, blood clots, and other vascular irregularities in the brain. The catheter is inserted into the femoral or carotid artery, and the injected contrast medium travels through the blood vessels on the brain. Patients frequently experience including headache, warmth, or a burning sensation in the head or neck during the injection portion of the procedure. A cerebral angiogram takes 2 to 4 hours to complete.
Coronary angiography is a special procedure that takes dynamic X-ray pictures of your heart.
The arterial puncture is typically given in the femoral artery, and the cardiologist uses a guide wire and catheter to perform a contrast injection and X-ray series on the coronary arteries. The catheter may also be placed in the left ventricle to examine the mitral and aortic valve of the heart. If the cardiologist requires a view of the right ventricle of the heart or of the tricuspid or pulmonic valves, the catheter will be inserted through a large vein and guided into the right ventricle. The catheter also serves the purpose of monitoring blood pressures in these different locations inside the heart. The angiogram procedure takes several hours depending on the complexity of the procedure. Pulmonary angiography. It is performed to evaluate blood circulation to the lungs. It is also considered the most accurate diagnostic test for detecting a pulmonary embolism. The procedure differs from cerebral and coronary angiograms in that the guide wire and the catheter are inserted into a vein instead of an artery, and are guided up through the chambers of the heart and into the pulmonary artery. Throughout the procedure, the patient's vital signs are monitored to ensure that the catheter doesn't cause arrhythmias or irregular heartbeats. The contrast medium is then injected into the pulmonary artery where it circulates through the lung capillaries. The test typically takes up to 90 minutes. Kidney angiography. Patients with chronic renal disease or injury can suffer further damage to their kidneys from the contrast medium used in a kidney angiogram. Yet, they often require the test to evaluate kidney function. These patients should be well hydrated with the intravenous saline drip before the procedure and may benefit from available medications like dopamine that help to protect the kidney from further injury due to contrast agents. During a kidney angiogram, the guide wire and catheter are inserted into the femoral artery in the groin area and advance through the abdominal aorta. the main artery in the abdomen and into the renal arteries. The procedure will take approximately 1 hour.
Fluorescein angiography is used to diagnose retinal problems and circulatory disorders. It is typically conducted as an outpatient procedure. The patient's pupils are dilated with eye drops and he rests his chin and forehead against a bracing apparatus to keep it still. Sodium fluorescein dye is then injected with a syringe into a vein in the patient's arm. The dye will travel through the patient's body and into the blood vessels of the eye. The procedure does not require x-rays. Instead, a rapid series of close-up photographs of the patient's eye are taken. One set immediately after the dye is injected and the second set approximately 20 minutes later once the dye has moved through the patient's vascular system. The entire procedure takes up to 1 hour. Celiac and mesenteric angiography involves X-ray exploration of the celiac and mesenteric arteries, arterial branches of the abdominal aorta that supply blood to the abdomen and digestive system. The test is commonly used to detect aneurysm, thrombosis, and signs of ischemia in the celiac and mesenteric arteries, and to locate the source of gastrointestinal bleeding. It is also used in the diagnosis of a number of conditions, including portal hypertension and cirrhosis. The procedure can take up to 3 hours depending on the number of blood vessels studied.
Splenoportography. So, a splenoportograph is a variation of an angiogram that involves the injection of contrast medium directly into the spleen to view the splenic and portal veins. It is used to diagnose blockages in the splenic vein and portal vein thrombosis, and to assess the strength and location of the vascular system prior to liver transplantation. Most angiography procedures are typically paid for by major medical insurance. Patients should check with their individual insurance plans to determine their coverage.
Radiation protection in angiography. Healthcare facilities performing angiography must comply with established standards to ensure the safety of both patients and healthcare professionals due to the use of ionizing radiation in the imaging process. Now, we will first discuss the fundamental principles of radiation protection, which comprises the justification, optimization, and dose limit. Justification. The first principle is the justification of radiological protection. This is the fundamental principle that an act of using radiation is permitted only when the benefits or merits outweigh the radiation risk. This principle plays a key role in patient safety, ethical considerations, informed decision-making, and regulatory compliance within the broader framework of radiation protection in healthcare.
The second fundamental principles of radiation protection is optimization. The medical team is responsible to ensure the radiological procedure provides quality images, adequate for diagnosis and treatment, while keeping the radiation dose as low as reasonably achievable. Lastly is the dose limits. The 2007 recommendations of the ICRP specify the effective dose limit for the occupational exposure, excluding radiation work in emergency, as 100 millisievert per 5 years average and 50 millisievert for the specific 1 year. The effective dose limit for the public is specified as 1 millisievert per year. The current recommendation of the ICRP is 100 millisievert per 5 years, so it is 20 millisievert per year, average of 5 years. This basics known as cardinal principle, which is important to achieve a LARA. So we have 3 important aspects as part of our protection. So in time, the radiation dose to an individual is directly related to the duration of radiation exposure. If the time changing which one is exposed to radiation is doubled, the exposure also will be doubled. The second principle is maximize distance. In radiography, as the distance between the source of radiation and the person increases, radiation exposure decreases rapidly. Lastly is maximize shielding. Positioning shielding between the radiation source and exposed persons greatly reduces the level of radiation exposure. Shielding used in diagnostic radiology usually consists of lead, although conventional building materials also are used.
Time. Total exposure time should be a LARA. Less exposure, less dose. Optimizing time in an interventional procedures considers number of images, number of X-ray passes per image, number of retakes, number of sign, runs under duration. Sign dose is much higher than fluoro dose. Frame rate. Determine the minimum number of frame rates per second needed. Distance. Know when the beam is on. Check where the tube is. Check where the X-rays enter the patient and will be scattered. The patient is the source of radiation. Keep distance. Put the tube under the table. Operator should avoid a place next to the tube. Step back from the patient, preferably behind shielding. Don't slouch under the patient, but stand upright. Keep your hands out of the radiation field. Put the detector as close as possible to the patient. If not needed in the room, leave the room. Try not to be standing next to the patient. Use power injectors for contrast material. Injections when feasible. Ergonomics in the room. Place the monitors away from the X-ray source. Analysis of danger.
Next is shielding. Lead shielding is critical for the protection of the medical personnel. Lead apron, thyroid shield, eyewear along with the gloves, cap, gonal shield, ceiling-mounted lead shield, table side shields, protective garments stop approximately 90% of scatter radiation, and lastly, check your aprons for cracks regularly. In patient position, the patient should be placed away from the radiation source to lower the skin dose. The image detector should be placed close to the patient to lower the necessary dose, less geometric blurring. The tube should always be positioned under the table or under the couch configuration to less scatter towards the personnel's eyes. Keep the patient's extremities out of the beam.
Personal dosimeters are typically thermoluminescent dosimeters or TLDs. It is recommended or sometimes obliged to wear two dosimeters. First is under apron worn at breast or waist level to give an estimate of effective dose and confirms the lead apron is being worn. Second is over apron worn at the collar level provides an estimate of the eye lens dose.